So you might have heard of this cocktail of drugs called the Holy Trinity. It's not up here. Anybody heard that term, the Holy Trinity? An opiate, a benzodiazepine, and muscle relaxant. That's the Holy Trinity. This is why a lot of these doctors are getting in trouble for unintentional overdose death. We can write 2 of those drugs. We can technically write 3 of them if you put tramadol, because it does hit on the opiate receptor. So you as a PA has the potential to write the Holy Trinity, which is a very dangerous combination. You can write Carisoprodol. I can tell you I've never written it, nor I never will write it. In the state of Oklahoma, it's always been a controlled drug. Up until a couple of years ago, each state had got to decide if it was a controlled or not. After a large study done by the Texas State Medical Examiner looking at the Holy Trinity, the FDA reversed their opinion on that, and Carisoprodol or Soma is a controlled drug in every state. Patients will ask you, as the new rookie PA, to write them Soma. Do not do it. It is one of the world's worst muscle relaxants on the market, but it is very good at tapping into the pleasure portions of the brain. Patients get euphoric. They feel like, ooh, it must be helping something because I feel better and I want more of that. Don't do it. Benzodiazepines. Don't go down that road. Don't go down it. CDC, or the FDA, put out a black box warning in August of last year. You need to know this. August 31, 2016, black box warning came out on every opiate and every benzodiazepine. You should not combine them together because of respiratory suppressing effects. We've known this forever, but it finally took the government to put a black box warning on those drugs to say, we've educated you forever, don't do it. People keep dying, don't do it. So it is in the guidelines, each of those that I told you just a minute ago, and they're listed in here, so you can go look up. Don't write the combination of those things. Don't go down the road of writing benzodiazepines. Let one of your other specialty folks, whether it be in psychiatry, let them take the onus of that if it's an appropriate form of therapy for patients. In our clinic, we started 3 years ago, no benzodiazepines written by us as providers. If the psychiatrist felt it was appropriate and they wanted to take the onus of that, that was fine at the time. However, we can't control how they're taking their benzodiazepines and they're still on opiates. So January of last year, we mandated none of our patients be on benzodiazepines. If you want to see crying, gnashing of teeth, fighting, arguments, yelling and screaming, you come sit a day in our clinic when we told patients no more benzodiazepines. So we had them wean off of benzodiazepines. We gave them 6 months, or we had to wean their opiate medication. I can't tell you how many patients we've released in the last 2 years weaning medicines because they won't come off benzodiazepines. Benzodiazepines are highly addictive medications that the FDA has never approved them for long-term usage. Short-term usage only, but they're being used long-term and they're very dangerous medications. Don't go down that road. Okay, we've talked about responsible opioid prescribing a little bit. We're going to talk a lot more when I do the addiction lecture. CDC opioid treatment guidelines, very important. The link is there. You go read it. It's boring, but it's fun. State of Oklahoma, they've got 2 sets of guidelines, the office-based as well as the emergency-based. You're going to be subjected to these guidelines, and you're going to need to know what they say when you get out and practice. I'm not going to babysit you and walk through each of these. You're going to be responsible for reading those for the state of Oklahoma. In our state, we have a prescription monitoring program. We were actually the first state in the United States to put forth a prescription monitoring program. The House Bill 1948 mandated in 2005 some changes to that prescription monitoring program. We now have always had the best prescription monitoring program in the world. All prescriptions within 5 minutes of being filled at the pharmacy that are controlled must go in the prescription monitoring program database. You as a provider will have a login. Every provider that writes controlled drugs is mandated to have a login and check that prescription monitoring program. I wear that thing out every day. My name logs in and out of there so many times they can't keep track of me because we pull one every time we see every patient before we write any controlled drug, and I would encourage you to do the same thing. State does not mandate that you do it every single patient, but there are mandates in there, and I would encourage whoever might be writing questions for this exam to have you read those and pull out some very important information out of there because the state does mandate And you're responsible for reading those if you're going to ever prescribe controlled drugs. In the state of Oklahoma, you have to have 3 licenses to write controlled drugs. DEA, Oklahoma Bureau of Narcotics, and the state medical license. Without any one of those 3, you can't write controls. But with those 3 things, you have to be aware of what you're getting yourself into. Okay? Addiction versus tolerance, we're going to deal with before at that particular lecture in 2 weeks. That's all the stuff we've gone through. Questions? Concerns? Yes?
So I shadowed at a pain clinic management, and the doctor was really excited about stem cell therapy.
Ah, beautiful question. Who was it?
It was in Manhattan, Kansas.
Okay, okay. So there's some great research that has been done with platelet-rich plasma as well as stem cell. I truly believe that if we can get the cost of stem cells down, this is going to change the world of chronic pain. There is a study going on in Edmond right now with an interventional pain doctor that is part of a worldwide study for intradiscal stem cell injection. And I've had 2 patients go through it. Both of them are now off of pain medication. So there's some very promising data with stem cell. Now there's 2 places that you can get non-aborted fetus cord stem cells in the U.S. One in Florida, one in California. Very, very expensive, but they're doing a lot of research with these cord stem cells. But what we found is that adipose stem cells are actually more effective, especially if they come out of you or me, okay? So there's a physician in Florida that's pioneering a lot of this, and she is doing stem cell injections of any part of your body you can think of with dramatic results. So basically, they go in and you get a mini tummy tuck, you get a liposuction, they'll spin them down and they'll re-inject them. And these could be joint injections, but one of the neatest things she's doing, IV stem cells. It's amazing, some of the data. I wish I would have thought to bring this. I have a picture of a patient who had basically, if you looked at an arteriogram of their lower extremity from the calf down, it was basically limited to no blood flow whatsoever. And the patient was given the option of amputation, or she decided to pay cash because stem cells are not approved by the FDA and it's all cash. So she paid $10,000 to have IV stem cell. 90 days later, I have the picture. She has blood flow in her left leg that looks no different than her right leg, and you can tell no difference in the wound. The wound is healed. That was a non-healing wound. The Doppler studies are amazing. The ankle brachial index is amazing. And this was stem cells. She's been through hyperbaric chamber, everything else you can think of. They've tried stent, all kinds of medicines. Stem cells did this. I know a doctor in town here, an interventional pain doctor that's part of this study, who had a torn lateral meniscus and posterior cruciate, needed surgery. Those things just don't heal on their own. He went and had stem cells done by this physician, interarticular. His scan is nearly 100% normal. So is it the end-all be-all in medicine? No. Can it be very promising? Absolutely. The problem is cost. Interarticular injections, you're talking about $5 grand. IV, 10 grand. I can set you up today with the doctor that would do them, and do them safely here in town. It's going to cost a chunk of money. Other questions? Okay. Oh.
I'm curious, does that work for, because at the rheumatology clinic I go to, they kind of talked about that. Does that work for like people who already have like OA that's already progressed to like 1 or 2? Like, does that work for that? Or have they shown any?
There's some early data at reversal of damage. Long-term data we don't have because it's just not there. It's not been being done long enough. So I can tell you there is some data. It's few and far between, but it's promising. Other questions? Okay, thanks.